Assalamualaikum warahmatullahi wabarakatuh. Good morning, good afternoon, and good evening, ma'am and my friends. I would like to say thank you for coming in my online presentation. It's great to see you all in this channel. Let me introduce myself. My name is Rizqita Destilyana, and I'm from the Faculty of Medicine at Bengkulu University. In this opportunity, I would like to present about this. Oh no, I'm just kidding, guys. We're not going to discuss about the trafficking of human organs. No. In this presentation, I would like to present about infectious complication in the renal transplant recipients. So I hope you can enjoy it. Infectious complication in the renal transplant recipient. Table of contents. First, abstract, introduction, materials and methods, result, discussion, conclusion. Presenting an article by Rizqita Destilyana, H1A020026. First, I will explain to you about the abstract of this article. The abstract of this article consists of aim, method, result, and conclusion. And then, why it's very important for us to discuss? Because infections represent one of the most complications among patients subjected to organ transplantation. Immunosuppressant therapy is the reason why transplant recipients are exposed to greater infectious risks. The baseline therapy or the one used to treat possible rejection during exposure to infectious agent, an invasive measure predisposed to various severe infections. And then, infections are differentiated as major and minor. The major ones demand parenteral treatment and further hospital admissions, and the minor ones are mucocutaneous or urinary in origin and treated with home oral therapies. A further classification subdivides post-transplantation infections according to the time of appearance, before the first month, between 1 and 6 months, and beyond 6 months after transplantations. The aim of the study was to estimate the incidence of infectious disease in patients subjected to kidney transplantation from January 2004 to September 2004. So, what is needed to carry out this research? First, the 121 kidney transplantation were obtained from 119 cadavers, and second, 2 from living donors with a male or female ratio of 90/31 and an average age for 45 years. Well, then we will discuss about what methods are used in this research and how to cure infection in organ transplant recipient. Trying to prevent infection, we adopt a protocol to appraise the immune state of recipient against the Gondi, CMV, VZV, EBV, hepatitis virus, hepatitis C virus, HCV, hepatitis B virus, HBV, and hepatitis D virus, HDV, human immunodeficiency virus, HIV, and M. tuberculosis and T. pallidum. This protocol permits us to begin appropriate pharmacological prophylaxis in case of transplantation from seropositive donors. The evaluation of immune state against the Gondi, hepatitis virus, HBV, and HCV, HIV, and CMV were also performed on the donor. For treatment of CMV infections, antiviral therapy with ganciclovir 3 mg per kilogram per day by month for 3 weeks was used both as prophylaxis in immunoglobulin G negative recipient of immunoglobulin G positive donors and as preemptive therapy before the appearance of clinical symptoms, and after that the viral load reached borderline levels, namely 100 positive leukocytes per 2 times 10 5 cells examined for pp65 antigenemia, and 1000 CMV copies per 2 times 10 5 leukocyte for diemia PCR real-time applied biosystem. And for VZV infections, the standard therapy acyclovir 800 mg per kilogram times 5 by month or 10 mg per kilogram intravenously every 8 hours as modified in accordance with the creatinine clearance, started after the appearance of typical papulovesicular cutaneous eruptions confirmed by a dermatologist and by antibody positivity. And the treatment for bacterial pneumonia consists of empirical wide-spectrum antibiotic therapy, bilactam, anti-pseudomonas, and anti-S. Pneumonia activity. Prophylaxis and therapy for P. carini pneumonia consisted of trimethoprim, sulfamethoxazole. For fungal pneumonia, it was amphotericin B, and for CMV pneumonia, accord with the creatinine clearance. The empirical antibiotic therapy of pyelonephritis, piperacillin, and tazobactam was based on symptomatology, dysuria, increased creatinine levels, and azotemia, and on result of kidney echography, blood culture, and urine culture. Finally, we come to the result section. Infectious complications appear in 25 patients, 20.7%, age between 29 and 60 years, average 45 years, with a male-female ratio of 17:8, and 3 patients experienced aggressive form of several infectious agents, pyelonephritis and VZV infection in 2 patients, and salmonella infection and pyelonephritis in the other one. The observed frequency was 12 CMV infection, 9 VZV, 3 pneumonia, 4 pyelonephritis, and 1 salmonellosis. The most frequent infection was CMV, which occurred in the first 3 months from transplantation in 9 of 12 cases. In 10, immunoglobulin M, immunoglobulin G, DNA PCR, and pp65 antigenemia positive patient, infection didn't cause disease in a particular organ, but a systemic pathology characterized by a febrile state. 1 patient died to CMV pneumonia after 3 months post-transplantation. Another patient showed gastritis diagnosed based on gastric mucosae biopsy, but with negative pp65 antigenemia. In 100,000 of cases, the infection was a consequence of viral reactivation because all the patients were positive for immunoglobulin G before the transplantation. And 5. Discussion. What changed the natural history of post-transplant opportunistic infections? The natural history of post-transplantation opportunistic infection is changing because of improvements in prophylaxis, diagnosis, and treatment of infections. How to reduce the risk of infection in a transplant recipient? Our center's experience show that closer checks and individuals' immunosuppression thus can reduce infections risks in transplant recipients. And what can we do to help physicians reduce the prevalence of infections? According to our data, we believe that a better knowledge of infection prevalence will help the physician. Conclusion. This study shows that a knowledge of infection prevalence can help the physician to establish a more specific, efficacious antimicrobial therapy despite the laboratory response not being available in a short time. And done. So that's all I can say. Hopefully the knowledge is useful, and thank you for your attention and goodbye. Wassalamualaikum warahmatullahi wabarakatuh.